So very good afternoon to all of you. So I'm Dr. Dimuthu Muthukuda. So I'm the consultant endocrinologist at Sri Jayewardenepura Hospital. And on behalf of the Sri Lanka College of Endocrinologists, I warmly welcome all of you who have joined today to these symposiums, which we have been having monthly. So this is the master clinical series on clinical session on thyroid disorders. And as we've got for our panel today, so we've got two experts, expert endocrinologists who are interested in thyroid disorders. So we have Dr. Kamani, Liyanarachchi, endocrinologist at Ratnapura Hospital, and we have Lalana, Dr. Lalana Ranasinghe. During this period, we are planning to discuss a few questions. So, a few interesting areas we've got related to thyroid disorders. And so the interesting thing is that we are going to follow a question and answer format. So that's what I'll be asking the relevant areas in the form of a question, and Dr. Kamani and Dr. Lalana will try to, answer those questions in a very sort of a practical manner. And if there are any questions, as we can, please keep the questions so that at the end of the talk, we can take up, as many as possible. So the first area that we are going to discuss today would be related to the prevalence of thyroid disease. So Dr. Kamani Liyanarachchi will try to answer some of the issues that we are going to highlight today. The prevalence of hypo and hyperthyroidism, and a little bit about autoimmune thyroiditis, especially with regard to the prevalence of autoimmune thyroiditis, and also a little bit about congenital hypothyroidism, so especially with regard to the screening programs that we are having in our country, and a little bit about the TSH, having a high, so how to interpret, having a high TSH. So Kamani would like to talk to us about these aspects.
Yes, thank you, Dimuthu. So what we thought to discuss in this forum are practical things as everyday clinicians we face. So, so let me share the slides. So when it comes to thyroid issues, when a patient comes and sits in front of us and they say, my relations told that I have this enlargement of the neck. And so they want us to go through to see what is wrong with them. So thyroid issues, there are several issues. One thing is just enlargement of the thyroid, which can have nodules. Some of these nodules could be malignancy. So when it comes to thyroid issues, they could be just enlargement. It could be hormonal issues. You have too much or too low thyroid hormones. Or it could be nodule, problems with nodule. And some of these nodules, rarely, less than 5% of these nodules can be malignant. So these are the broad issues of thyroid problems. And in this talk, we are actually going to focus more on hormonal issues. So actually, if you talk about the epidemiology of thyroid disease globally, the nodular thyroid disorders are more common in iodine deficient areas. And then iodine replete areas have more autoimmune thyroid disease. So this is practically seen in Sri Lanka. Because in Sri Lanka, before the iodination program was initiated in 1995, we were actually having a lot of nodular goiters. So Sri Lanka was endemic for goiters. That means more than 10% of the population had goitrous enlargement. But actually, following this iodination, if you go through the literature, there was a drastic drop of goiters. We can see practically also the young population has less goiters. If you look at the older generation, they have large goiters. But actually, the prevalence of autoimmune thyroid disease became higher. So in one study, they found that their prevalence was up to 20%. So what are the factors which affect thyroid disease? So one is the iodine status, as we just discussed. Then the gender, because females are at higher risk of developing thyroid issues. Smoking is a factor because smoking increases autoimmunity of the thyroid, as well as it can cause thyroid eye problems, worsen thyroid eye conditions. The other things are genetics, because we know that thyroid problems are familial. Alcohol and also thyroid issues are related to age, because there are particular ages where you get higher incidence of autoimmune thyroiditis, etc. So when it comes to the prevalence, hypothyroidism is more common than hyperthyroidism. There is a varying degree of occurrence of hypothyroidism worldwide, and the American Thyroid Association, the guidelines we follow, advises to screen for thyroid problems after the age of 35 years. They recommend to repeat the thyroid functions by doing a TSH every 5 years. They identify iodine deficiency and autoimmune thyroiditis as the commonest cause of hypothyroidism worldwide. Prevalence of hyperthyroidism is less common, less than 2% in the population. And out of the causes, Graves' disease is more common, the most common cause. And again, like we said, autoimmune thyroid diseases are more common in iodine sufficient areas. So Graves is again an autoimmune problem. So it's also more common in iodine sufficient areas. Okay, so one question asked by our patients is that once they are diagnosed with hypothyroidism, they want to know whether they have to take this tablet lifelong. So they are asking, doctor, do I have to take this till I die? So what is the evidence behind this? So actually this depends on the degree of their thyroid hormone elevation. So we know some of these patients can worsen the thyroid problem, but significant amount when the TSH is less than 7. So when it's only mildly elevated, about half of them may go into remission, and that occurs within the first 2 years. Normalization of TSH beyond 2 years of treatment is less common. So another case that we see is so I took these common scenarios that we face day to day. A young lady, 26-year-old, who has been diagnosed with hypothyroidism, and we have diagnosed her as having autoimmune thyroiditis. She has small kids at home, 3-year-old child or maybe 4-year-old, and she wants to know, the first thing a mother's instinct is to see whether she will wonder whether my children will get affected. So this is a common question that we face in day-to-day practice. So she would ask, should I look at the thyroid functions of my child, and what age should we screen them? So actually autoimmune thyroid disease, which is the commonest cause of hypothyroidism in Sri Lanka at the moment, is quite rare under the age of 3 years. The commonest, the highest prevalence is actually during the puberty time. So between early to mid-puberty. The other case scenario is a lady who is a 24-year-old lady who is diagnosed again with autoimmune thyroiditis. She's pregnant, and now she's asking whether what is the risk of her unborn child having hypothyroidism. So this is another common question. So basically, she's asking whether this child is at prone on getting congenital hypothyroidism. So when it comes to congenital hypothyroidism, these are the 3 main reasons for getting congenital hypothyroidism. First thing is dysgenesis. Dysgenesis means the genesis or the structural issues of the thyroid gland. The thyroid gland may be absent or may be hypoplastic or ectopic. This is the most common cause of congenital hypothyroidism. Most of the time, these are sporadic in occurrence, not familial, but very rarely, less than 5% of the cases are familial. The next reason is dyshomogenesis, where these are autosomal recessive conditions which are inherited. So it's rare, quite rare, and issues with the hormone production of the thyroid gland. The other thing is iodine deficiency. So these are the 3 main reasons for having hypothyroidism. What about this autoimmune thyroiditis in the mother? So in in studies, actually, scientific evidence have proven that even though the TPO antibodies, so autoimmune thyroiditis means you have autoantibodies. So the main home autoantibodies that you have is the TPO antibody and the trap thyroglobulin antibody. Thyroid microsomal antibody is same as the TPO antibody. So these actually do cross the placenta, but it does scientifically it's proven that there is no effect on this for the thyroid function. But when it comes to TSH receptor antibodies, in the literature, there are few case reports. So TSH receptor antibodies are seen in Graves' disease. So sometimes you have blocking TSH receptor antibodies. There are case reports where TSH receptor antibodies can causing transient congenital hypothyroidism. But when it comes to autoimmune thyroiditis, these antibodies are not seen or very rare. Because TSH receptor antibodies are specific for Graves' disease, it's not seen in autoimmune thyroiditis. So they don't actually get congenital hypothyroidism. The other reason is this elderly people having high TSH. So this is the other common scenario that we face. So the important thing about the TSH is the TSH level increases with the age. Actually, the TSH rises after the age of 70 years. Till the age of 70 years, there is no significant difference in that. The reference of a person who is more than 70 years, the reference is above 7.5. So this is clinically incorporated into guidelines in the European Thyroid Association. So if you look at this guideline, if someone is more than 70 years and their TSH less than 10, we don't usually treat them. But if it is less than 70 years, you can see on the left-hand side where when the TSH is less than 10, we usually treat according to the routine guidelines. If the patient has symptoms, then we would treat. Okay, so the other important aspect is, for example, in our diabetic clinics, we do screen patients for thyroid disease. Is it relevant? Is it important? So this is why we have put this slide. So we know that autoimmune thyroiditis is associated with other autoimmune problems, and hypothyroidism is known to associate with certain genetic syndromes like Down syndrome and Turner syndrome. But the other thing is, there is a clear association with type 1 diabetes, and also there is higher prevalence of hypothyroidism in type 2 diabetic patients also. This is proven globally, and even in a study done in the National Hospital of Sri Lanka in 2014, it was found that about 20% of the patients with type 2 diabetes had hypothyroidism. So I think we have gone through the important clinical aspects on the prevalence, Dimuthu.
Yes, a lot of interesting, important things as you have discussed, Kamani. And as you said, this autoimmunity in Sri Lanka is like it's rising in our population. So it's postulated to be due to at least partly over-iodization may be responsible for that. Yeah, okay, Kamani. Then as we will move on to the other question, so Lalana will be addressing. So what is the association with dyslipidemia, thyroid disease with dyslipidemia, ischemic heart disease, and psychological issues? Lalana, I would like to talk on that.
Yes, so let me share my screen. Yeah. So right. So moving on to comorbidities associated with thyroid dysfunction. If we look at hypothyroidism, it is associated with dyslipidemia, cardiovascular disease, depression, dementia, subfertility, and also obesity and type 2 diabetes. If we look at hyperthyroidism, it is associated with atrial arrhythmias, especially atrial fibrillation, cardiovascular disease, strokes, dementia, osteoporosis, and fractures. So if we move on to thyroid dysfunction and cardiovascular disease, Both overt as well as subclinical thyroid dysfunction is associated with increased risk of cardiovascular disease. And in both hyper as well as hypothyroidism, there is increased cardiovascular mortality as well as total mortality. And moving on to hypothyroidism. In hypothyroidism, it can cause atherogenic lipid profile. The LDL cholesterol level goes up, and also there's increase in lipoprotein small a, homocysteine, and CRP, and all of which are non-traditional cardiovascular risk factors. And hypothyroidism increases arterial stiffness and can cause diastolic hypertension and endothelial dysfunction. So all these factors increase risk of atherosclerotic cardiovascular disease, especially coronary artery disease. Hypothyroidism causes left ventricular dysfunction, both systolic as well as diastolic dysfunction, leading to congestive cardiac failure. So if we look at hyperthyroidism also increases arterial stiffness and causes mainly systolic hypertension with a wide pulse pressure, and it is associated with a hypercoagulable state, and there's increased risk of coronary artery disease. Hypothyroidism causes diastolic dysfunction and heart failure, and heart failure can also be due to increased demands on the heart, can cause high output cardiac failure. And there's increased risk of supraventricular arrhythmias, especially atrial fibrillation, and there's high risk of stroke. Therefore, in a patient with cardiovascular disease, it is important to look for thyroid dysfunction because it may be the etiology or it may be an aggravating factor. So with that, let's move to the other question.
Okay, Lalana, so the thyroid disease, as you described, could be considered as a metabolic disease risk factor. So very nicely, the involvements, I mean, with regard to the target organs were described by Lalana. So let's move on to the next question, diet and thyroid disease. So Kamani, I mean, it's a lot of, I mean, it's not an uncommon scenario, people coming and questioning you on, you know, these lifestyle things, like whether there are any dietary restrictions. It's very commonly we encounter this issue. So I would like to tackle this question.
Yes, Dimuthu. So this is again a common question asked from our patient. So apparently it's not only a question related in Sri Lanka, even in America, this is a common question. So is there a thyroid diet? That's what these people also ask. So because of this, because it's a common question, there was an editorial collaboration with this thyroid association with Medscape, and they have this document you can go through. So what is the so what is the evidence? So we know that there are some goitrogens in our diet. So there are few reports where people have taken exorbitant amounts of certain goitrogenic substances and got hypothyroidism. But what actually is important is that these substances, when taken in normal quantities that we usually take in day-to-day practice, have no effect on the thyroid functions, particularly if you have a if you are not iodine deficient. So what are these dietary substances which can affect goiter formation and hypothyroidism? So one is cruciferous vegetables like cauliflower, broccoli, cabbage, kale, turnips, bok choy, and Brussels sprouts, and also soy products. So these are rich in a substance called glucosinolate, which inhibits the thyroid iodine uptake. The other important thing is by cooking these goitrogenic properties, these substances are significantly broken down. So the goitrogenic properties are significantly low when you cook them. So that's how we consume most of the time. The soy products also have a substance called isoflavonoids, which inhibits the thyroid peroxidase, which is an enzyme important for the thyroglobulin iodination. So we know thyroxine is a hormone which has iodine. So the thyroid peroxidase is the one which incorporates iodine into this. So this enzyme is inhibited by these isoflavonoids. Again, here also, according to the literature, the actual significance is quite low, when particularly in iodine sufficient populations. Then cassava, it's a common thing that we eat. So it's a possible cause of goiter in Central Africa. And again, there is no significant, so they have done studies in school children in Africa, and they found that if there is no iodine deficiency, there is no significant effect with this. So just for the completeness sake, there are other micronutrients that are important, which are available in our food. So selenium is actually beneficial for the thyroid gland. So they found that having low levels of selenium increase the risk of goiter and thyroid nodules. And in studies, they found that in short term, taking selenium reduce the thyroid autoantibody levels also. But this has not been, up to now, has been represented in long-term studies. Short term, they found that there is a reduction in thyroid antibodies. So what are the sources of selenium? Selenium is found to be rich in fish, and also in meat products. So even in grains, breads, significant amount of selenium is there. Routine selenium supplementation is actually not recommended if you are taking a normal balanced diet, but sometimes we do use it in patients who have Graves' orthopathology. Iodine, we have already mentioned, and as Dimuthu mentioned, adequate iodine is good, but too much iodine is also not good, because that also can cause immunogenicity. So increase in the thyroid immunity in Sri Lanka, for example, the global thing. Yes.
Okay, Kamani. So the next question, so what is secondary hypothyroidism and how to monitor treatments? We know that because we use, hypothyroidism and primary. So what it means is actually it's primary hypothyroidism. So interchangeably, we use both terms. So when it comes to secondary hypothyroidism, so do you all know what it means and, how to monitor treatment? While on treatments, how to monitor the adequacy of replacement. So Lalana will address that question.
Yes. So, So unlike primary hypothyroidism, secondary hypothyroidism is a rare condition, and it is due to dysfunction at the level of pituitary, and the TSH secretion is reduced, and therefore stimulation on the thyroid is reduced to produce thyroid hormones. So secondary hypothyroidism should be suspected in a patient who is already having known pituitary disease, like if there's a past history of pituitary adenoma, if there is a history of hypophysitis, and also in those patients who are at high risk of developing pituitary disease, like history of head injury, those who are having iron overload in thalassaemic patients. In such patients, we need to screen them for secondary hypothyroidism periodically, especially if they are symptomatic. The other thing is, like, if your patient is having hypothyroid symptoms and other symptoms like headache, visual field defects, and multiple pituitary hormone deficiencies, then we need to check for secondary hypothyroidism. And also, if your patient is having several symptoms of hypothyroidism, but if the TSH is normal or low, then you need to think of secondary hypothyroidism. So when it comes to diagnosis of secondary hypothyroidism, the issue is TSH is unreliable, because in secondary hypothyroidism, generally TSH is either low or it may be inappropriately normal. So you have to go by free T4 levels, and usually they have low free T4 levels. So how are you going to evaluate, or how are you going to start treatment? Well, the most important thing is, first you need to assess anterior pituitary function, especially you need to rule out hypoadrenalism. And then if there's no known history of pituitary disease, then you need to image the pituitary with either contrast CT pituitary or a MRI pituitary. So why you need to rule out hypoadrenalism, because if you start thyroxine in a patient who is having hypoadrenalism, it can precipitate adrenal crisis. And then if you don't have facilities to do investigations, you can even go by 9 AM cortisol level. If it is significantly low, then you can start your cortisol, hydrocortisone treatment. If it is indeterminate, and if you don't have access to this ACTH stimulation test or short synapton test, then you can start steroids, and we generally start hydrocortisone and thyroxine together because thyroxine will take some time to act. So when it comes to thyroxine replacement therapy, it is more or less similar to thyroxine replacement therapy in primary hypothyroidism. So we can start thyroxine based on the patient's weight. So full replacement dose like 1.6 micrograms per kg per day can be started in young patients. But if your patient is an elderly patient or with a history of cardiovascular disease, then we have to start off with a lower dose. And then when it comes to monitoring, usually we have to go by free T4 levels. And we usually do the free T4 levels after about 4 to 6 weeks after starting thyroxine. And when you take blood sample for free T4, blood sample should be taken before ingestion of T4, either before ingestion of thyroxine or 4 hours after ingestion of thyroxine, because just after ingestion of thyroxine, there can be slight peak, slight increase in T4 levels. And then the target free T4 levels for most of our patients would be, the target would be to keep free T4 level at upper half of normal range. But in elderly patients, we may consider to keep free T4 levels at lower half of normal range.
Okay, Lalana. Yeah, so next we'll talk about treatment principles for hypothyroidism. So what are the tests that we can use? Is it only TSH, or is it a combination of TSH and free T4? So what about the place of T3? And at what time are we going to do these tests? So what time of the day? And so when we are doing the tests, what about the morning dose of thyroxine, prior to doing tests? And if there is persistently elevated TSH despite being on apparently adequate doses of thyroxine, so what could be the reason? So all those would be tackled by Kamani.
Yes, thank you, Dimuthu. So hypothyroidism is a common problem. So we start them on treatment with thyroxine. So the dose depends on whether the thyroxine, the TSH elevation also is determines the amount of thyroxine that we are going to give to these people. So in overt hypothyroidism, we give about 1.6 micrograms per kg. In subclinical hypothyroidism, where you have elevated TSH, but you have normal T4 and T3, where there is some sort of compensation. So there is a mild hypothyroidism, we give lower doses. So when we follow them up, what is the most important test that we do? Because we can see even in our practice, clinicians do different tests. So actually when it comes to, so actually TSH is the most reliable marker for the follow-up of adequacy of the thyroid, the dose that we are giving. So we see some clinicians asking T4 and all, but it's actually the TSH which is the most reliable marker. So then we target the TSH. The target of TSH is between the normal range. The American Thyroid Association says to keep it in the normal range, but that also you have to individualize. For example, if someone is planning pregnancy, you target the TSH to be less than 2.5. And if someone is middle-aged young person, you tend to keep it between 0.5 to 2.5. But someone who is older, you tend to keep TSH at a higher level. Even 5 is enough for people or elderly people. So so as Dimuthu mentioned, is there a particular time or should the patient be taking the morning thyroxine or not? So this all depends on what test we are going to do. So most of the time we are actually asking the TSH because that is the most reliable marker. So when we ask a patient to do TSH, if there is a circadian rhythm, because we know all these pituitary hormones, there is a circadian rhythm that might affect the results. So whether this circadian rhythm is important when it comes to TSH. So in studies, they found that the TSH level, the peak level actually occurs in the night when you are sleeping. So from the midnight, so some studies say up to 5 o'clock in the morning and some studies say up to 8 o'clock in the morning, your TSH level is at the peak. But after that, after about 10 a.m. in the morning, the TSH level goes down. But so is this significant clinically? So when it comes to so we don't have a lot of data in this area, whether we had to take an early morning sample before 10 o'clock. So the clinical guidelines are not very specific. Even the lab guidelines are not very specific when it comes to the timing of the TSH, what time we should do, whether it's okay to do it at any time of the day. It's not very clearly mentioned in these guidelines. But sometimes this timing is important when it comes to pre-pregnancy counseling, when you're treating a patient with subfertility, where you try to keep the TSH less than 2.5, and also at the diagnosis of subclinical thyroid diseases, this may be important. So at the moment, so this area is a place where I think we need more research. So, but the important thing is all these reference ranges that we use, they are done in early morning. So particularly they are done before 10 a.m. in the morning. So at the moment, even though it's anecdotal, even though the guidelines don't mention a specific time, it's best to do your patient's thyroid function, the TSH, if you are doing in the morning before 10 a.m. Okay, so I have some patients who go to the labs because you tell your patient to take the thyroxine early in the morning. So just when they wake up, so they go to do their blood test and I ask for a TSH. They go to do the blood test to the lab and then from there, they are turned down telling, you have taken your thyroxine, the T4, you have taken your thyroxine, so we can't do the blood test. You have to come in 4 hours time, or else they say we have to do it on a different day. So what is the rationale behind this? So actually, if we are asking for TSH, taking the morning sample of thyroxine does not affect because the TSH has a long half-life. But if you ask for a free T4 in your patient, then that problem is there. Because, when we take thyroxine, we have a stable level in your blood. But initially, when you take the thyroxine tablet, for the first 4 hours, there is a peak before it stabilizes to the normal level. So if you take the thyroxine tablet, because the thyroxine tablets we have is levothyroxine. That means it contains T4. So when you take this thyroxine tablet and you take a blood within 4 hours for free T4, you will have an increased level of free T4, which is abnormal. So if you ask for a free T4 only, ask your patient not to take the morning tablet before the blood test. If you do the TSH, it's all right to take the morning tablet. So here I have from the internet. This is patient advice leaflet that they have printed. So you can go through. So they also have this question, should you take your thyroxine before or after the lab test? So if you look at this, picture, you will see, if the doctor has asked to take free T4, take your tablet after the blood test. But if the doctor has asked TSH or T3, you can take your tablet at any time. There is no restriction. I hope it's clear. So the other question Dimuthu asked, and I think we have some questions in the chat box regarding this. We are treating a patient with hypothyroidism and we are monitoring the TSH. But sadly, the TSH is not coming down. So what do we do? So what are the causes of persistent high TSH in a patient who is already diagnosed with hypothyroidism but not responding? So the commonest cause worldwide is poor compliance to thyroxine. So actually, it's very common for poor compliance. Sometimes patient will not come out with that also. So they say use don't be judgmental, try to be non-judgmental and ask these questions. So the other important thing, so if they insist that they have taken the thyroxine every day, the other thing is it could be due to the lack of absorption. Even though the patient has taken the thyroxine tablet, the absorption of it would have been affected. It could be due to the patient's GI factors. The patient might have malabsorption. So it is important to know that for the thyroxine to be absorbed, you need to have adequate acid in your stomach. Actually, thyroxine is absorbed in the proximal part of the small intestine, but the gastric acid is important for this thyroxine to be absorbed. So various conditions like atrophic gastritis, H. pylori infections, and in fact, problems with the small intestine like celiac disease that can cause malabsorption, or certain drugs which reduces acid level like PPIs. And then there are drug factors. So the tablets that you take may be expired or may be damaged because of moisture or heat. So that drug factor is important. The other important thing here is when we take thyroxine from various commercial, there are various commercial formulations. Even though the thyroxine is there, the substitutes are different. So we have found actually the different types of thyroid tablets may have different levels of absorption. It could also be due to increased turnover, like using enzyme inducers like rifampicin. If the patient is on these drugs, it can cause increased turnover of the thyroid hormones, causing, even though we give a large amount of thyroxine, it's not working properly. Or it could be due to excretion of thyroxine, which is seen in nephrotic syndrome. You would notice that patients with high nephrotic syndrome have a higher incidence of hypothyroidism. And they have seen that with the albuminuria, some amount of the thyroid hormones are also excreted. Then it could be due to some problems with the assay, or maybe it's a wrong diagnosis. So heterophile antibodies and macro TSH, maybe the patient is not actually, the patient in these conditions are actually euthyroid, but they have a elevated TSH. So you need to, and the wrong diagnosis. So what is this? What do you mean by wrong diagnosis? So you have to consider this if the patient has significantly elevated TSH, but you don't have a low free T4. So you have normal T4, but if you have a normal T4, but markedly elevated TSH level, you have to consider these diagnoses. So wrong diagnosis means it could be thyroid hormone resistance, a form of thyroid hormone resistance, and then it could be TSH-OMA, but TSH-OMA clinically the patient is actually toxic. So there may be instances clinically where you may be dealing with one of these two conditions. So let's go a little bit about heterophile antibody. So we use immunoassay methods to actually get the thyroid hormone, the TSH levels. Now, what happens here in the first picture, you will see we have this capture antibody and TSH is the analyte, and then you have the labeled antibody. So if the labeled antibody binds the analyte, and labeled antibody gives a signal to say how much TSH is there. But what happens in heterophile antibodies, without the analyte, there is an antibody which is a mediator mediating between the capture antibody and the label antibody, so that the label antibody is sticking with the capture antibody even without the analyte. So you don't have TSH, but this heterophile antibody or that particular antibody is making the label antibody give signals. Okay, so these are the few things that I already discussed. Absorption of levothyroxine occurs in the proximal part of the small intestine, the jejunum and the ileum. But the acidic pH in the stomach, which particularly occurs in the fasting state, is important for the subsequent intestinal absorption. So you recommend the thyroxine to be taken in the fasting state, and it is very important to keep on fasting for at least 30 minutes, but ideally 60 minutes before you consume anything except water. And then if you are working in the night, a night shift worker, at least 3 hours following the evening meal is required as fasting before you consume the thyroxine. So thyroxine formulation is important. As I told you, the commercial formulations, they have different abilities to be absorbed. So you will note that if you give the thyroxine, if the patient has a sudden change in the thyroid functions, you have to ask the patient whether they changed the thyroxine formulation, whether they took a different formulation, maybe because of unavailability, etc. Then loss of potency can happen because of various environmental factors like exposure to heat and moisture. If you keep your tablets in the car, it can get damaged. And sometimes patients just take it without checking the expiry date. Even that can be there. So these are straight from the American Thyroid Association guidelines. So they recommend to look for things like malabsorption with H. pylori, infection, atrophic gastritis, etc. And these are the drugs so they say this list of drugs which affect the thyroid absorption is increasing over time. So new drugs are being identified as being affecting the thyroxine absorption. So the common drugs that we face day to day are the calcium tablets. The calcium, for example, if your patient is pregnant and taking thyroxine, which is hypothyroidism, and is pregnant, we ask them to take calcium from the second trimester onwards. So generally, you ask them to have a 4-hour separation, but this is actually not tested. So generally, we ask them to have a 4-hour separation after taking the thyroxine, to take these the culprit drugs, if they are taking them at least 4 hours after taking thyroxine. So this is a weak recommendation because these are not tested. These are anecdotal recommendations.
Okay. Okay, Kamani. So that was a very comprehensive answer. So when we are evaluating a patient with thyrotoxicosis, so what initial investigation? So what is the initial assessment is like, Lalana? So would like to address that area.
So moving on to thyrotoxicosis. So in thyrotoxicosis, there's increased metabolic rate, heat production, and sympathetic activity, giving rise to typical clinical features. So clinical presentation, there can be a wide spectrum of clinical presentation. I have listed the common clinical features. Generally, patients present with a weight loss, increased appetite, excessive sweating, palpitations, tremors, irritability, and poor sleep. So if we look at etiology, the commonest cause for thyrotoxicosis is Graves' disease. Other common causes include toxic multinodular goiter or a toxic adenoma and thyroiditis. The less common causes include iodide-induced thyrotoxicosis, extrathyroidal causes like factitious thyrotoxicosis or struma overi, TSH-induced thyrotoxicosis or OTSH-OMAs, and HCD-induced causes like choriocarcinomas and HPs. So, when we are clinically evaluating a patient with thyrotoxicosis, we have to look at several things. We have to assess several things. So first, we need to get an idea about the severity of thyrotoxicosis. So thyrotoxicosis can be mild, moderate, or severe. And sometimes, rarely, the first presentation can be with a thyroid storm. So if your patient is really ill with having fever, then you need to think whether you are dealing with a patient with a thyroid storm. So in that case, we need to treat aggressively. And I'm not going to go into details of thyroid storm here because of lack of time. And then we need to look for complications, especially we need to look for presence of atrial fibrillation and heart failure. So detailed cardiovascular system examination is important. So generally, overall, patients with thyrotoxicosis, about 10% of them can develop atrial fibrillation, and the risk of atrial fibrillation goes up with advancing age and with underlying cardiovascular disease. And if atrial fibrillation is present, then we need to involve the cardiologist in the management. And generally, these patients need rate control and anticoagulation. And studies have shown that after achieving euthyroidism, about 60% of patients can revert back to sinus rhythm. Then we need to get an idea about the etiology of thyrotoxicosis. In Graves' disease, generally, there may be a family history or past history of thyroid disease. Patients may be having other associated autoimmune diseases like type 1 diabetes and vitiligo. And generally, these patients have a diffuse goiter with a bruit. And if you find Graves' orbitopathy, pretibial myxedema, and thyroid acropathy, those are characteristic of Graves' disease. So those with toxic nodular, toxic marginodular goiter, on examination, we will find a goiter with nodules. And in subacute thyroiditis, generally, there's a preceding history of preceding febrile illness or upper respiratory tract infection. And they usually complain of pain in the neck. And on examination, thyroid may be slightly enlarged diffusely with diffuse tenderness over the thyroid. So painless thyroiditis is thyroiditis due to Hashimoto's thyroiditis or Hashitoxicosis. So it usually causes a mild thyrotoxicosis. Generally, the duration is short, less than 2 months, and there may be no thyroid enlargement or small diffuse goiter. Then the next thing is, if your patient is having Graves' disease with orbitopathy, it is very important to see whether the orbitopathy or the eye disease is active. If it is active, how severe the eye disease. So the activity and severity can be assessed using activity and severity scores proposed by the UGOGO. So these are available even online. You can go through these scores. And if the eye disease is active and if it is moderate to severe in severity, or if eye disease is sight-threatening, these patients need urgent referral to the eye surgeon for further evaluation and treatment. Then it is important to ask about smoking status, especially in patients with Graves' disease, because smoking can precipitate or aggravate Graves' orbitopathy. And if you are seeing a patient, a woman, it is very important to discuss about pregnancy plans, because if there are fertility wishes, then the type of treatment, antithyroid medication that we are going to use is different. We usually go for PTU rather than carbimazole. And also it is important to discuss the timing of pregnancy. Generally, we want to wait until the patient achieves euthyroidism, and until it's better if they can wait till they achieve a remission with antithyroid drugs, at least if they achieve stable thyroid function at least for 6 months. And if your patient is not willing to stay until they go into a remission, then we have to consider definitive treatment, especially surgery, early for these patients. Right. So moving on to investigations. Yeah. So moving on to investigations in the patient with thyrotoxicosis, to confirm the diagnosis, we need to do both TSH and free T4. So we expect free T4 to be elevated and TSH to be suppressed. So in the presence of suppressed TSH, if the free T4 level is normal, then we need to do free T3, because some of these patients can have T3 toxicosis, or what is called mild thyrotoxicosis. And then to look for complications, if you suspect atrial fibrillation, you need to do a ECG with rhythm strip. And then I have listed various investigations that can be useful to confirm the etiology of thyrotoxicosis. So generally, I mean, we don't need to do all these investigations in each and every patient. So if your patient has characteristic features of Graves' disease, that's a clinical diagnosis. In the absence of that, we need to do these investigations. So ultrasound neck is very useful. So it will tell you whether patient is having a diffuse goiter or whether there are one or more nodules in the thyroid. And also it is important to look at the vascularity of the thyroid. So generally, If it is due to Graves' disease, the vascularity is increased, and in thyroiditis, we expect the vascularity to be reduced. And it is important to look at the echogenicity of thyroid. If the echogenicity, usually in autoimmune conditions like autoimmune thyroiditis and Graves' disease, there is heterogeneous echogenicity. Usually in the thyroid, the echogenicity is uniform. So TRAP or thyrotropin receptor antibody is not routinely recommended. It may be useful in selected patients where you have a doubtful diagnosis of Graves' disease. And if you're thinking of subacute thyroiditis, then inflammatory markers, ESR, CRP, quite useful. Those things will be markedly elevated in subacute thyroiditis. So in some patients, it may be helpful to do a T3 to T4 ratio. Here we use total T3 and T4 rather than free T3 and free T4. So in Graves' disease and toxic adenomas, generally they tend to have higher degree of T3 elevation, because in these conditions, type 1 deiodinase levels are high, and therefore T3 release from the thyroid gland as well as peripheral T4 to T3 conversion is increased. Therefore, if you look at the T4 to T3 ratio, and if you take these units, nanograms for T3 and micrograms for T4, and if you calculate the ratio, if the ratio is more than 20, it is suggestive of Graves' disease or a toxic adenoma. But if the ratio is less than that, if it is less than 16, then it is more suggestive of thyroiditis. Whether to use free T3 to free T4 ratio, well, there are no established nomograms, but some studies have suggested that if you're using free T3 to free T4 ratio, a ratio more than 0.3 would suggest Graves' disease, and less than that, lower ratio will be more suggestive of thyroiditis. Then nuclear uptake scan, we have two types of scans, technetium-99 scan and I123 scan. Out of this, I123 scan is better, and this may be indicated in patients with Graves' disease if the diagnosis is doubtful, or in patients with toxic nodules, and sometimes in thyroiditis. So moving on to various uptake patterns in various disease conditions, if you are using I123 scan, here I have shown if you look at Graves' disease, there is usually a generalized increase in uptake, diffuse uptake. And if you look at an autonomous nodule, generally there's a focal increase in uptake with suppression of the remaining gland. So if it is a toxic multinodular goiter, the uptake is usually patchy. And in thyroiditis, the uptake will be markedly reduced. So here you can see a hot nodule here, and on the top you can see a cold nodule. So scans can be used to see whether a thyroid nodule is hot or cold. Generally, hot nodules are almost never cancerous, but cold nodules may or may not be cancerous. About risk of thyroid cancer in a cold nodule is about 20%. Right, so this diagram summarizes your approach to patient with thyrotoxicosis based on their investigations. So generally in thyrotoxicosis, the TSH will be suppressed and free T4 will be high. So if the TSH is suppressed but free T4 normal, then we need to do the free T3 levels. If the free T3 is elevated, it is T3 toxicosis. And we need to treat with antithyroid drugs. So if the free T3 is normal, so if TSH is suppressed, both free T3 and free T4 are normal, then it is, we call this subclinical hyperthyroidism. So if we diagnose subclinical hyperthyroidism, which is a biochemical diagnosis, we need to repeat thyroid functions after about 6 to 12 weeks. So rarely you can get this pattern. Rarely you see elevated free T4, but TSH is not suppressed. TSH can be either normal or increased. So if you come across that scenario, then the possibilities include, the first thing is you need to rule out assay interference. So Kamani has already discussed the heterophil antibodies can interfere with TSH assay in certain patients. So you need to, first thing is to rule out assay interference. And once you have ruled out assay interference, then you are left with two possibilities. If your patient is clinically thyrotoxic, the possibilities include TSH secreting pituitary adenoma or TSHoma. The other possibility is thyroid hormone resistance. Then in a patient who is having sort of vague symptoms of thyrotoxicosis, if both TSH, T4 are normal, then you can rule out thyrotoxicosis, right? So this diagram sort of summarize how you are going to investigate to come to decide the etiology of thyrotoxicosis. So quickly go through it. So if your patient is having obvious, features of Graves' disease, like if there is presence of orbitopathy, if the goiter is moderate to large, and if thyrotoxicosis is moderate to severe, then you can clinically diagnose Graves' disease. You don't need to do all the investigations to confirm, right? So if in the absence of those features, if your patient is having a nodular goiter, then the best thing would be to go for a radioisotope uptake scan, because if you do ultrasound scan, it will show the presence of nodules, but in ultrasound scan, you cannot differentiate whether the nodule is active or not. So to confirm that nodule is the culprit, nodule is the one which is overactive, you need better to go for uptake scan. So I have described various uptake patterns, so you can decide whether it is a toxic nodule, toxic multinodular goiter, or a thyroiditis based on your uptake scan, right? So in certain patients, TRAB may be useful. For example, if your patient does not have, characteristic features of Graves' disease, when you do the ultrasound, there are no nodules. So in such patients, you may do TRAB or thyrotropin antibody levels if it is available. So if TRAB is positive, then it is Graves' disease. Well, if TRAB is negative, still it can be Graves' disease. About 5% of patients with Graves' disease, especially the mild Graves' disease, can be TRAB negative. So in that case, it is better to go for uptake scan or an ultrasound scan. The best thing is to go for a isotope uptake scan, and that will, depending on the pattern, you can come to the diagnosis. So if uptake scan is not available, then you can use ultrasound to diagnose the etiology. So in the ultrasound in Graves' disease, we would expect the thyroid blood flow to be high, sometimes maybe normal in mild thyrotoxicosis, whereas in thyroiditis, the vascularity, thyroid blood flow will be reduced. And I have already discussed the utility of T3 to T4 ratio that can also be used if you are suspecting thyroiditis, if your imaging is not available or if it is not conclusive, and that will be helpful to differentiate between Graves' disease and thyroiditis.
So, okay, Lalana. So we are actually running behind our scheduled time. As Kamani, would you like to quickly, can you give a quick answer to the next question? As what are the important facts about antithyroid drugs? So how to start, how do you decide on the dose, and what are the side effects that you need to look for, and when to stop treatment? So would you like to give a quick answer, Kamani?
Yes, Dimuthu, thank you. So what are the antithyroid drugs? So commonly used drugs are thionamides. They are the antithyroid agents. And when it comes to the thionamides, there are two forms, the carbimazole and propylthiouracil. So actually, methimazole is not available in our country, but it's the active form of carbimazole. And so propylthiouracil is less commonly used. So when it comes to the American Thyroid Association, they say use methimazole in almost virtually all patients if possible. This is because of certain side effects with propylthiouracil, but they give some exceptions. That is the first trimester of pregnancy where PTU, propylthiouracil, is preferred, and also in severe thyrotoxicosis like in thyroid storm. So that is that, and so we commonly use the carbimazole actually more than the propylthiouracil. So I'll go through the doses later on, but there is another reason why we are worried about these anti-thyroid agents, because of actually we are worried about severe side effects like agranulocytosis. So this recommendation is before you initiate, they do recommend, this is not an absolute thing, but it's always best to have a baseline full blood count. And also liver enzymes. So that's what they mention as anecdotal evidence. This is a weak recommendation, but it saves the doctors, because if you develop neutropenia later on, then you will have evidence in the initial state what this patient's basal neutrophil count was. So it's always better to have a basal level of transaminases and the neutrophil level. And then so you can see where I have highlighted, if you have a basal neutrophil count of less than 1000 and a liver enzyme level of more than 5-fold, then you should think twice before you start these anti-thyroid agents, is what they say. Okay, so let's go to the doses. So the dose of the anti-thyroid agent actually depends on the level of thyrotoxicosis. So T4, more than T3 toxicosis, we have commonly patients who have both T4 and T3 elevation. So here the task force is giving a rough estimate of how much carbimazole or methimazole is required from the degree of the TSH elevation. So this, you can go through this later on. Because of the timing problem, let's go on. So once the other thing is, once the patient is yield euthyroid, so the next thing you do is in 6 weeks, you do the thyroid function. So we have seen patients, so what thyroid function should you do? Actually, it's the T4 and T3, not the TSH, because the TSH suppression may take time for it to recover. So actually in the following the next visit, which is usually we check after 6 to 8 weeks, we had to do the free T4 and T3. And in that, if there is euthyroidism, you reduce the dose of carbimazole or methimazole, you can decrease by 30 to 50%. So this is what the guidelines mention. So what are the important side effects when you treat these patients with anti-thyroid agents? So the important, and this is even an MCQ for the MD trainees and also medical students, that the side effects with the neutropenia is dose related. So that is one question. So generally it appears that the side effects of methimazole or carbimazole appears to be dose related, whereas propylthiouracil is less clearly dose related. Now these drugs, the common side effects are minor side effects, which is seen in about 10 to 15% of the people who are treated. The commonest one is actually urticarial rash. This is usually responding to antihistamines. You can stop the anti-thyroid agent. You can change from carbimazole to PTU and give antihistamines with or without steroids. Also, you can use shorter. And then the commonly this urticarial rash occurs after about 18 to 22 days. Then patients also develop arthralgia and GI complications, which is common to any drug. But the most important thing are not these minor side effects. But when you actually initiate people on anti-thyroid drugs, you have to mention roughly that they may develop a rash, they may develop some joint pains. And then, but ideally, you are supposed to give in writing or a leaflet telling that there are some to be aware about these drastic side effects. One is agranulocytosis. So the definition of agranulocytosis is an absolute neutrophil count of less than 500. So different studies show different prevalence. It's in one study in Japan, it was 0.3%. In another study, it was about 0.1%. So the important thing is it usually occurs in the first 3 months. Very rarely, it can occur later on also. And then higher doses are associated with agranulocytosis of carbimazole. But with propylthiouracil also agranulocytosis seen, but less association with the dose of propylthiouracil. Elderly people are at a greater risk, it seems, to get agranulocytosis. So most of the time, the experts actually say routine monitoring is not actually indicated, but you can monitor in the first 3 months. if you are worried about your patient. You have to mention that if the patient develops sore throat and fever, they are the most common presenting symptoms. You give a full blood count prescription, ask them if they develop sore throat or fever, or even ulcers in the mouth. They can ask them to do the full blood count, and withhold the antithyroid drugs till the full blood count is seen by a doctor. So agranulocytosis is defined as less than 500 neutrophils, but when to stop the antithyroid agent is if the granulocyte count is less than 1000. The important thing is there's cross-reactivity between the PTU, because both PTU and methimazole both can cause agranulocytosis. So switching to the other is actually contraindicated according to the guidelines. Okay, so the other important side effect is hepatotoxicity. The occurrence is less frequent, but it's more common in people taking propylthiouracil rather than methimazole. In people who are taking propylthiouracil, the clinical picture is also different, because with propylthiouracil, they get an elevation like a hepatitis picture, where there is increase in liver enzymes, whereas in methimazole, what they get is a cholestatic type of picture. Now, the important thing is asymptomatic elevation of liver enzymes can occur in untreated hyperthyroidism itself can cause elevated aminotranslerases. And PTU, once you commence PTU also, you can have a mild increase in liver enzyme, which is not that significant, which reduces with time. Routine monitoring, according to the guideline, is not recommended, but in small letters, they also mention if you are monitoring, you may monitor within the first 120 days, where it is the first 120 days is where you get this type of picture, the hepatotoxicity commonly. So PTU-related hepatotoxicity is a form of allergic hepatitis with marked elevation of liver enzymes. There is a significant fatal rate, causing the FDA to put a black box warning against the PTU. So they found that in various studies, also in adults and children, this is recorded. This type of a fatal, very high level of liver enzyme elevation. But they found that children and adolescents are more susceptible. So it is now recommended to avoid PTU in children. As I said, hepatotoxicity in methimazole has a different picture. It can cause hepatitis-like picture, but the common one is the cholestatic picture. So they recommend, the American Thyroid Association recommends, if you have a mild elevation of AST/ALT, you don't have to discontinue. But if it is more than 3 times upper limit of normal, better to stop the propylthiouracil. The other important side effect is vasculitis. This is seen more common with propylthiouracil, and some develop ANCA-associated p-ANCA is positive in these people, and also drug-induced lupus-like picture. Yes.
Okay, Kamani. Lalana, there's another very important question. If the patient is not responding to maximum tolerable doses of antithyroid drugs, so for example, let's say that the patient has developed serious side effects, so what are the adjunctive medical therapy that is available to us, Lalana?
Yes. So, yeah. So in this situation, there are several medications that can be used, including glucocorticoids, iodide, like potassium iodide, polystyrene, lithium carbonate, and some people even have tried plasma exchange if patient is having severe thyrotoxicosis and complications like atrial fibrillation, to rapidly lower T4 levels before going ahead with definitive treatment like surgery or nebulized surgery. So in these patients, generally we go for definitive treatment options early, and until such time to achieve euthyroidism, we can use these drugs. So glucocorticoids are quite useful and effective. Prednisolone can be used at a dose of either 1 milligram per kg per day, high dose, or a low dose like 20 milligrams per day. If you look at literature, even low dose like 20 milligram a day has been quite effective. And so you start with this dose, and then depending on the response, you can titrate the dose and taper off the steroids. So steroids act by its immune suppressive effect, and also it reduces peripheral T4 to T3 conversion. The problem with steroids, its long-term use is limited because of adverse side effect profile. So moving on to inorganic iodide, potassium iodide. So it acts by blocking mainly thyroid hormone release, and also inhibit thyroid hormone production as well. So if you are planning a thyroidectomy, this potassium iodide is quite useful. So it has additional advantage of reducing the vascularity of the thyroid, and thereby produce thyroid blood flow and intraoperative blood loss during thyroidectomy. However, studies have shown that there is no significant post-op complication difference with potassium iodide. So we have two preparations, Lugol's iodine or SSKI, or saturated solution of KI. So if you're using Lugol's iodine, the dose is 5 to 7 drops TDS. With SSKI, it's 1 to 2 drops TDS, and we usually give this treatment for 7 days prior to surgery. The problem with iodide is that its efficacy loses with time. So here in the picture, I have shown this acute Wolff-Chaikoff effect in picture A. So after giving an iodide load, this iodine is transported into the thyroid follicle via sodium iodide symporter. And this iodine load within the follicle inhibits thyroid peroxidase and inhibits thyroid hormone formation and release. But with time, there's down regulation of the iodide symporter, and thyroid hormone production resumes. Even though escape phenomenon like this has been described, small studies have shown that potassium iodide can be useful for long-term treatment as well. For example, in this Japanese study, they have shown that potassium iodide treatment in patients with Graves' disease who had adverse reactions to antithyroid drugs resulted in about 60% of patients achieving control long-term, and about 40% of the responders achieved remission after 7 years. So moving on to cholestyramine, now this is a bile acid sequestrant. If you look at excretion of thyroid hormones, they are excreted through bile, and in the intestine, with this bacterial enzymatic activity, these hormones are degraded and reabsorbed into the circulation. We call this enterohepatic circulation of thyroxine, and this is blocked with cholestyramine. So cholestyramine can be quite effective in reducing T4 levels due to any cause, including even in thyroiditis and factitious thyrotoxicosis. You can use cholestyramine. So the usual dose is 4 grams BD to start off, and if patients can tolerate, dose can be increased up to 4 grams 6-hourly. And GI side effects are common and include bloating, flatulence, and constipation. If you're using several drugs to control thyrotoxicosis, we need to keep in mind that cholestyramine may interfere with absorption of other drugs. So we have to educate patients to keep at least 2-hour gap between ingestion of various drugs. So moving on to lithium carbonate, it's a widely available drug. Lithium acts mainly by inhibiting thyroid hormone release, and it inhibits thyroid hormone production as well. So we have 2 preparations. Immediate release preparation is the one that is available in government sector. Extended release preparations are available at private sector. So if you're using immediate release tablets, we can start off with 250 milligrams BD and then gradually increase the dose depending on the response, up to 1,250 milligrams per day. But we need to be very cautious in elderly. We have to use small doses for them. And an escape phenomenon similar to iodide has also been described with lithium carbonate. However, studies have shown that it can be effective up to 6 months. So it can be used even for long term. The problem is with lithium is that it has a narrow therapeutic range. So we need to be very cautious if you're using lithium. You have to do lithium levels, you have to monitor it, and then we need to educate the patient about symptoms of lithium toxicity, what to do if they develop those symptoms. And of course, there are certain drugs which can increase risk of lithium toxicity, and lithium is contraindicated if your patient is pregnant or lactating. Right.
Okay, Lalana. So I think Kamani and Lalana, we may have to stop here because we've got only limited time and we've done about 15 minutes extra. So what do you think, Kamani and Lalana? So there are some important questions actually, which the attendees have posted. Is about 10
Yes.
questions are there. So shall we go through some of the questions?
Yes.
Yes.
I think that's
Yeah. Yes, it's a very important question. Is what is your recommendation for cardiac patients who had been diagnosed as having hypothyroidism? So
Right.
what do you think, Kamani? Cardiac patients with hypothyroidism, when you are starting thyroxine and when you are escalating the doses, is what are the precautions that we need to follow?
So the thing with the cardiac patient is we know that thyroid hormones are the hormones which increases metabolism. So in patients who are hypothyroid, they have a low heart rate, their general metabolism is low. So if you start on the usual dose of 1.6, if someone is having overt hypothyroidism, if you start on straight away with this full replacement dose, they might not be their weak heart might not be able to go on with it because the metabolism suddenly increases. So what we do is we usually start with a smaller dose and escalate the dose. So we calculate the total dose. If it is overt hypothyroidism, we calculate the total dose from 1.6 micrograms per kg. But for this dose, we gradually escalate the thyroxine. So we usually start with 12.5 micrograms and like slowly over 2 weeks, like we can increase the dose to the expected level of thyroxine. Meanwhile, we also need to tell the patient that if they develop any cardiac angina or any cardiac chest pain like symptoms to inform us. So then we can even slower, like keep in a lower level and then gradually increase even at a slower pace.
Okay, Kamani, so I think that was a very good answer. So the next question, Lalana, so do all thyroid nodules need radioiodine uptake scans? Do we have to do radioiodine uptake scans in all thyroid nodules? If not, so when is it indicated?
Yeah, right. So if you look at guidelines, what they recommend is to do an uptake scan in all patients, but it may not be sometimes practically possible to do the uptake scan in all patients with thyrotoxicosis. So generally, what we do is we do the ultrasound scan of the thyroid, and then we assess the nodule, right? So generally, like if the surrounding thyroid tissue looks normal, I mean, if the echogenicity is fine, if the surrounding tissue looks normal, then if patient does not have any features suggestive of Graves' disease, that sort of a patient, maybe you can, clinically treat, because these uptake scans are not widely available. So generally, in such a patient, we usually go for definitive treatment rather than long-term carbimazole use. So it could be either radioactive iodine treatment or surgery if there is a suspicion of malignancy based on scan findings, and if you do FNAC, which is suggestive of malignancy. But in a patient with nodular goiter, like if you do the thyroid scan and if you find that this surrounding tissue is having this heterogeneous echo pattern, then that is suggestive of thyroiditis. So that sort of a patient, it could even be Graves' disease. So in that situation, it is better if you can do TRAB. I mean, to rule out Graves' disease, if TRAB level can be done, that is quite useful. Again, the problem is it is not widely available in private sector. It's not available in government sector, and it's in private sector, it's quite expensive, about 20,000 rupees also. So that is the problem. So if in a patient with altered echogenicity of the surrounding thyroid, that is a real indication to go for uptake scan if TRAB cannot be done, because in such a patient, it is important to to decide on treatment. Dimuthu, would you like to add anything to that?
So I think it was comprehensive enough, Lalana. So let's move on to the next question. It's about T3 toxicosis. Someone had asked, so when does it occur and how to monitor? I think to give us a very simple answer, T3 toxicosis we see, so it's mainly T3 that is elevated, compared to free T4. So in Graves' disease, early stages, we see this pattern, and also with the toxic adenomas, we can see mainly T3 toxicosis. And just like with, standard thyrotoxicosis, we monitor with TSH and T3. So the next question, why in elderly people we keep the T4 in the lower normal range in secondary hypothyroidism? Would you like to answer that question, Kamani? Elderly people with secondary hypothyroidism, why do we keep the free T4 in the lower normal range?
So again, in elderly, physiologically, there is lower amount of metabolism in the body. So again, as we know, there is so I discussed about the increase in the TSH with age. So similarly, the amount of metabolism and everything is basically coming down with the age when you're above 70 years of age. So you don't expect to increase the heart rate. You don't expect to have the high metabolism of a young person in an elderly gentleman. So that is a gentleman or a lady. So that is why we try to keep this free T4. So in secondary hypothyroidism, we don't go by the TSH, it's the T4, free T4. So that's why we keep it in the low normal range. I would any other panelists also, I would like to invite Lalana, because you spoke about secondary hypothyroidism.
Yeah, I think, that is the answer. It's because in normal people, there's an age-related decline in T4 levels, and that's why we need to keep it at lower range.
Yeah, someone had asked about this, the syndromes, Marine-Lenard syndrome. I think you can read up on internet. So that's the combination is where you can get functioning nodules of the functioning thyroid nodules and Graves' disease. So you can read up further on internet. And so there's another question: does expensive trap test, or is the expensive trap indicated in patients with suspected Graves' disease? I think Kamani I think you gave I think we discussed about, doing TRAB, and Lalana and Kamani both mentioned about, TRAB being very expensive, and in difficult cases, doubtful cases, how it becomes useful to us. I think we don't have to discuss about it again. The other question is, when is LT3? T3, when is it indicated? So would you like to answer to that question, Lalana?
In a patient with thyrotoxicosis?
No, I think hypothyroidism, when is LT3 indicated? I think it's not indicated. In our day-to-day practice, it's only, isn't it, Lalana? It's only thyroxine.
Yeah.
I think for research purposes in some centers internationally, may be indicated, but in our setting, we could say that it's only monotherapy with LT4. So what would you say, Lalana?
Yes, I don't think it's available in our country.
Yeah.
Yes.
Even theoretically, it's not indicated. I mean, at present, yeah.
Some studies, they have given this for psychological well-being,
Mm.
isn't it, Lalana?
Yeah.
So they have tried, because even when patients are on the correct dose of thyroxine as judged by the TSH, if the patient still tells that they have like less psychological well-being, I think some centers have tried the leothyroxine, the T3, and it's contraindicated in pregnancy, isn't it?
Yes, and a lot of practical difficulties or challenges are there, because when you compare the half-lives of T4 and T3, and the transition, those comparisons, like all are, so many difficulties are there. So for practical purposes, at least, it's not indicated in our setting.
it has a short half-life, and
yeah.
then you need to give it several times per day. Whereas
Yes.
this levothyroxine, the T4, has a long half-life. It's given daily. Yes.
Yeah. And so there's another question. Someone had asked earlier, I saw, was when you give iodine containing items, you know, with iodine, oral iodine, so how does that cause autoimmunity? How
Yes,
does iodine cause autoimmunity? So that was the question, if I'm not mistaken.
Yeah, I answered it. Actually, when I prepared this presentation, only I read extensively. So what they say is now this, how we produce the thyroid hormones are by the thyroglobulin molecule getting iodinated. So when you have a lot of iodine, when you have a very large amount of iodine in the body, these thyroglobulin molecules get over iodinated, it seems. And they are somehow immunogenic. So these over-iodinated thyroglobulin molecules, which are inside the thyroid colloids, the cells, are immunogenic. So that's what they mentioned.
Yeah. So in other words, we can say that iodine increases the immunogenicity of thyroglobulin. No? So it's the...
Yes.
Yeah. So any other thing that you would like to mention, Lalana? I think most of the questions we have answered. And about this marine, so that you can read up, because I think as we sometimes see.
Would you like to discuss, Dimuthu? Like, so we have issues like how to differentiate between TSH-HOMA and thyroid hormone resistance in remote settings. So that is something that we have issues, a lot of issues practically.
I don't
what
think.
do you think about that?
Remote setting we can.
So one thing is, I think, family history, because most of the time thyroid hormone resistance are familial, autosomal dominant. So maybe we can test the relatives, because most of these tests are very expensive. Even the sex hormone binding globulin can be used as a marker for thyroid hormone action, but that is also not available in the government sector. So
actually that concept has to be very clear, because I think that should be the starting point. Whenever free T4 is elevated, TSH not being suppressed, you have to identify that pattern. Free T4 is high and TSH is also normal or high. So that pattern, if you can identify, I mean, at any setting you can identify, that should be the thing that we have to learn. So from there onwards, I think theoretically speaking, we need to, before thinking about these two possibilities, always we have to think about assay interference. We have to, because that is the commoner thing, compared to these two entities. So exclude assay interference, then only we come to these two differential diagnoses: TSH secreting pituitary adenoma and we call it RTH, resistance to thyroid hormones. So out of the two, I think as far as I can remember, TSH-HOMA would be a little commoner than, I don't know whether am I correct, Kamani, Lalana? TSH-HOMA is little, because okay, so TSH-HOMA, being an adenoma, so there may be evidence of like hypopituitarism, due to the mass effect if it's a macroadenoma. So
commonly they are macroadenomas, isn't it?
Yeah, those days, in the past, it used to be macroadenomas, but the thing is that nowadays with the development of the imaging and neuroimaging, we tend to catch more and more microadenomas. So earlier that was the pattern, having being macroadenomas. So, and the other thing is that, so one would ask that, okay, can't we do an MRI of the pituitary looking for an adenoma? So in simple terms, you can diagnose it, but the thing is that pituitary incidentalomas are there to complicate things further. So having that biochemical pattern, straight away doing a pituitary MRI, seeing a tumor may not mean a TSH, but anyway, you can do an MRI because things would get much clearer, and If it's like a very big, I mean, sometimes like even without doing anything, you may be able to pinpoint and say that it's a TSH-OMA, but complicated, complex cases you may find. So ideally speaking, you have to do the rest of the biochemistry to differentiate between the two. And the gold standard for RTH, resistance to thyroid hormones, it would be genetics. So that is the gold standard. But it's not easily doable. It's expensive. It is available, but it's expensive. And so the biochemistry wise, as Kamani mentioned, a couple of tests are there, which should aid us in differentiating. So the one thing is that sex hormone binding globulins that we take as a tissue marker of thyroid hormone action. So the SHBG is being produced by the liver, and T4, I mean, it's taken as a tissue marker of thyroid hormone activity. So we do have it here. And in TSH-OMA, thyroid hormone works in the on the peripheral tissues. So SHBG will be elevated, whereas RTH, there will be resistance, and it will be relatively lower than what we see in the other condition. And then we have dynamic testing. So in endocrinology, always we like to do dynamic testing. So we do the TRH stimulation test. So when we do the TRH, it's not available in Sri Lanka, but once we have done, I think Lalana was also involved in managing that patient. So when we give TRH, so what happens is that in TSH-OMA, TSH, autonomously, there is an autonomously secreting tumor, and although we give, further stimulation by giving TRH, there won't be further rise of TSH, whereas with RTH, so there will be a rise. So there are cutoff values for that. And so those are the differentiating tests, basically. Then we interpret the MRI, and whenever needed, we can look at the TSH, the TFTs of family members and genetics. So those are the tests available to differentiate between TSH-OMA and RTH, Kamani.
Dimuthu, there is one, I think one last question we'll go through. The person has mentioned a comment. He's asking, aren't the TSH-OMAs more toxic compared to thyroid hormone resistance? If you can give a small,
Yeah, because usually RTH, what happens is that, depending on the thyroid receptor involvement, it's very, it's going to be a very complex answer if you're going to discuss in detail, but usually the people, they have palpitations, and in children they can be like autistic like behavior, and cardiac wise they are toxic, but the rest of the tissues like the periphery, they show resistance to thyroid hormone. So what you said was correct. Whereas TSH-OMAs, free T4 will be as in, just like with standard thyrotoxicosis, they are toxic. So, there's no difference basically, and they can have a goiter also because, the TSH is high, and they can have a goiter. Sometimes what happens is that due to misdiagnosis, due to, not appreciating what the real diagnosis is, you can even offer thyroidectomy. So it's a lot of, wrong diagnosis, associated with wrong management steps we see with TSH-OMA. So they are more toxic basically, but we have
clinically, it might be difficult to differentiate.
It's difficult to differentiate. Yeah. But they are just like, they have other symptoms also in TSH-OMAs. Whereas RTH, you see the symptoms are very subtle most of the time.
Okay.
Okay. Thank you very much. Yeah, thank you very much, Kamani and Lalana. So I think the attendees today, and thank you very much for being with us. I think we've taken about 1 hour and 45 minutes, like it was too long. But anyway, thank you very much. And I'm sure the meeting must have been very useful to all of you, especially for medical and endocrine trainees, and also other medical officers who were with us. Thank you very much once again, Kamani and Lalana, and all the attendees.
Thank you.
Thank you.
Okay.